Welcome to Mastering the Gut, Module 1, Correlation to Chiropractic, Reoccurring Subluxation, and Degenerative Disc Disease. The traditional chiropractic model for organ dysfunction is a vertebral subluxation with cord-level irritability firing to the sympathetic nerves. This causes a hypersympathetic response, but due to philosophy-based anatomy, physiology, and neurology, there is no mention of what occurs with the blood supply to the organ. During a hypersympathetic response, the blood vessels around the organ are vasoconstricted, reducing the blood supply necessary for proper organ function. Chiropractic adjustments have been known to affect the autonomic nervous system by helping to downregulate the sympathetic nervous system and promote parasympathetic activity. The sympathetic or the parasympathetic nervous systems control the blood flow throughout the body. If the patient is sympathetic dominant, the adjustment will stimulate the parasympathetic at the vertebral level, sending blood to the dysfunctional organ. Depending on the degree of sympathetic dominance, the patient may feel better for a period of time or may fully recover. The parasympathetic dominant or insufficient patient will not notice any difference. Chiropractic adjustments to specific segments of the spine are known to stimulate the sympathetic or parasympathetic nervous system. For example, upper cervical adjustments affecting the C1 vertebra, the atlas, can stimulate the parasympathetic or even the enteric nervous system via the vagus nerve, the 10th cranial nerve. Lower spinal adjustments, including the sacrum, can also stimulate the parasympathetic nervous system. Adjustments to the mid-back can stimulate the sympathetic nervous system via the sympathetic chain ganglia. Chiropractic philosophy-based anatomy, physiology, and neurology place primary emphasis on nerves controlling every cell in the body, while at the same time there is an absence of muscles, nerves, and blood supply to the muscles controlling vertebral motion. Every picture associated with chiropractic is a dry spine. This makes it very difficult to explain the subluxation or disc-degeneration by excluding parts of the body intimately associated with those conditions. Functional Splanchnology uses the working laws of health described by Dr. DeGarnett in the early 1900s. No part of the body can be understood except in relation to the whole. No part of the body can be isolated from its relationship to other parts of the body. No part can exist only in and of itself. When a part loses its synchronization and reciprocation, it continues to shift, but that compensation is inappropriate to the state of the rest of the body. After the primary lesion, everything the body does is defensive in nature. The defensive measure continues until the primary lesion is corrected. Splanchnology is a specialty within the chiropractic field first introduced by Dr. Major Bertrand DeGarnett in the early 1900s. Functional Splanchnology might best be described as a neuroendoimmune supersystem-based organ rehabilitation that assesses the visceral conditions of a patient with reoccurring subluxation and degenerative disc disease, treating the patient using non-invasive, non-pharmaceutical therapies and chiropractic modalities. Components of the neuroendoimmune supersystem control every cell in the body. There are specific muscles requiring blood and nerves to maintain control of vertebral motion. These components play a role in subluxation and disc degeneration. 3 spinal muscles, interspinalis, rotatories, and intertransversarii, provide proprioceptive input to stabilize the lower vertebra relative to the superior vertebra. The intertransversarii and intraspinalis act as large proprioceptive transducers, their value not lying in the force they can exert, but in the muscle spindles they contain. Precise muscle spindle input of the paraspinal muscles is essential for accurate positioning of the pelvis and lumbosacral spine during activities of daily living. Standard chiropractic vertebrae are completely devoid of any muscles. Blood supply and nerves control muscle tonicity. Muscle tone moves and stabilizes bones. The regulation of skeletal muscle blood flow is important for two reasons. First, skeletal muscle serves important locomotory functions in the body because of its contractile properties. This is important for voluntary movement, walking, swimming, postural control, and involuntary movements such as respiration. Contracting muscles consume large amounts of oxygen to replenish ATP that is hydrolyzed during contraction. Therefore, contracting muscles need to be able to increase its blood flow and oxygen delivery in order to support its metabolic and contractile activities. Second, about 20% of cardiac output at rest goes to skeletal muscle, which means that about 20% of the resting systemic vascular resistance is determined by the vascular resistance of the skeletal muscle. For this reason, changes in skeletal muscle resistance and blood flow can greatly influence controlled vertebral motion. There are several characteristics of skeletal muscle blood flow. Skeletal muscle accounts for 20% of the cardiac output and systemic vascular resistance. During extreme physical exertion, more than 80% of the cardiac output can be directed to the contracting muscles. Therefore, skeletal muscle resistance becomes the primary determinant of the systemic vascular resistance during exercise. There is a close coupling between oxygen consumption and blood flow. At rest, skeletal muscle blood flow may be 1 to 4 milliliters per minute per 100 grams. Maximal blood flow may reach 50 to 100 milliliters per minute per 100 grams, depending on the muscle type. Therefore, blood flow can increase 20 to 50-fold with maximal vasodilation or active hyperemia. Coordinated rhythmical contractions, such as running, enhance blood flow by means of skeletal muscle pump mechanisms. Sympathetic innervation produces vasoconstriction located on the vascular smooth muscle located in the abdominal compartment. There is a significant amount of sympathetic tone at rest, so that abrupt removal of the sympathetic influences, such as in parasympathetic dominant or insufficiency patients, can increase resting blood flow 2 to 3-fold. Skeletal muscle blood flow shows a moderate degree of autoregulation. Blood flow is strongly determined by the local regulatory tissue and endothelial factors such as tissue hypoxia, adenosine, potassium, carbon dioxide, hydrogen, and nitric oxide. During exercise, these local regulatory mechanisms override the sympathetic vasoconstrictor influences termed functional sympathetolysis. Vasodilation is due to a direct effect of the extracellular acidosis associated with hypercapnia on the vascular surface of smooth muscle. Hypercapnic acidosis increases prostaglandin PGE2 and nitric oxide production. When stimulated by epinephrine, vascular beta-2 adrenoreceptors produce vasodilation of peripheral muscle vasculature. Spinal muscles lose proprioceptive input due to vasomotor disturbances, hyperemia, ischemia, hypoxia, and hypercapnia, resulting from gastrointestinal inflammation disrupting proprioceptive input of the lower vertebra in relation to the superior vertebra and the ability to control motion of that vertebra. Inflammation occurring in the organs induces a short reflex into the paravertebral ganglia. The paravertebral ganglia irritation induces a vasomotor disturbance. This is carried out through the components of the NEI supersystem to the muscles, providing proprioceptive input in controlling the vertebral motion at the level of the vertebra associated with that organ. The vasodilation or vasoconstriction of the blood supply to these muscles induces a hypertonic or hypotonic tone, altering proprioceptive input. This induces a compensatory response above and below the involved vertebral level. A subluxation of motion develops because of the muscular control of the involved vertebra, allowing motion in excess of normal function and necessity. The musculoskeletal response from this subluxation of motion makes it necessary for specific muscle splinting or fixation to occur. This fixation leads chiropractors to focus on the compensatory lack of motion rather than the excess uncontrolled motion cause. The splinting controls motion by restricting movement, but also impairs normal circulation to the innervated areas of the involved segment. It is not that the area is fixated, although this may occur, but a fixation normally occurs when the part's reciprocal partner is in a subluxation of motion, out of sync and out of reciprocation. The fixated part then becomes restricted by muscle splinting or adhesion formation. The problem is in the fixation, but the solution is in the subluxation of motion. The circulation impairment may occur in the form of hyperemia or ischemia. The impairment of normal blood supply and lymph flow sets the stage for viscous pathology. The deviation of the viscous from a healthy, normal, or efficient condition forces a defensive response through a reflex fixation of soft tissues. Chiropractic manipulative reflex technique, also known as CMRT, is used to remove the reflex to the subluxation of motion, restoring controlled motion, and through such removal, restores visceral function by restoring circulation. After which the vertebral adjustment can now become effective in maintaining innervation. The adjustment will then rearrange the structure and restore controlled motion at the specific vertebral level. When the viscera do not function properly, there are two factors influencing the ability to restore normal function to the organ. One is a lack of NEI supersystem control through the vasomotor systems, which is supported through lab testing and nutritional supplementation, and the other is malposition of the organ, also known as splanchnology. CMRT assists in normalizing blood supply to the offended viscera, and SOT chiropractic reestablishes the structural balance, neural and cerebral spinal fluid flow, while lab testing helps determine the proper nutritional support. Wear and tear is not the only cause of back pain, arthritis, and disc degeneration. Some is due to bacterial infection within the gastrointestinal tract. Reactive arthritis is induced by many different bacterial species. Some are pathogenic, while others are commensal bacteria that have converted into pathobionts. Reactive arthritis symptoms can be similar to spinal stenosis symptoms, rheumatoid arthritis, or even osteoarthritis joint pain in some patients. But they are often caused by inflammation triggered by an infection elsewhere in the body. In most cases, chiropractic, involving adjustments, stretching, and strengthening exercises for the back, neck, and other joints, is an effective therapy for reactive arthritis. Symptoms will usually abate after 3 to 6 months with a possible flare-up just prior to 12 months, and then a 15 to 50% incidence of symptoms at some point in the future. Back pain is the most common symptom to recur, and an unfortunate 20% or so of the patients may suffer from chronic arthritis after initial bacterial infection and reactive spondylitis. Inflammatory cytokines travel through the blood supply throughout the body. This is made worse if bacteria are able to translocate into the blood supply. These cytokines and chemokines influence vasomotor control of the blood supply. The resulting vasodilation and hyperemia, or vasoconstriction and ischemia, cause inflammatory responses resulting in tissue damage in different ways. Controlling infection in this group of patients is very important, as reactive arthritis symptoms can worsen existing joint damage. Patients must maintain high standards of hygiene in terms of food handling, oral and gastrointestinal health, and take steps to reduce bacterial contamination, as enteric or gastrointestinal reactive arthritis may occur if they contract an infection such as Salmonella, Shigella, Yersinia, or Campylobacter, or H. pylori. Reactive arthritis symptoms usually arise 1 to 3 weeks after infection and can persist for 3 to 12 months. Some patients' symptoms last longer, possibly due to inadequate control of inflammation and resulting joint damage. Inflammation in the spine, or spondylitis, may also lead to postural changes, osteophyte growth, muscle stiffness, and ligament calcification. All of this done in attempts to defend the body and stabilize the spine. The growth of osteophytes in the spine can cause spinal stenosis, resulting in back pain, nerve pain, or sciatica. Reactive arthritis symptoms, however, will usually affect the knees, ankles, or feet primarily, with other joints less affected. Achilles heel pain is quite common, and a number of patients go on to develop bone spurs or osteophytes on the heels that then cause further pain. Some patients experience such mild symptoms that they remain unaware of the condition and just continually don't feel good. Because of philosophy-based anatomy, physiology, and neurology, these symptoms are confined to the philosophical paradigm of the healthcare professional, and they may only discover the infection should another symptom arise, such as prostatitis in men or a burning sensation when urinating for both men and women. The intervertebral disc is the largest predominantly avascular, aneural, and alymphatic structure in the body. It provides articulation between the adjoining vertebral bodies and also acts as a weight-bearing cushion dissipating spinal loads. The intervertebral disc is composed of outer collagen-rich annulus fibers and a central protoglycan-rich nucleus pulposa. Superior and inferior cartilaginous end plates, thin layers of hyaline-like cartilage, cover the ends of the vertebral bodies. The intervertebral disc is a complex anatomic and biochemical structure. It is composed primarily of fibrocytes and chondrocytes. They're anatomically segregated into an elaborate avascular macromolecular matrix of collagen and protoglycans. Chronic inflammation and altered mechanical loading contributes to intervertebral disc degeneration. However, biochemical factors playing a role in disc degeneration have received limited study. Intervertebral disc degeneration is characterized by increases in the levels of pro-inflammatory cytokines TNF-alpha, IL-1, IL-1B, IL-6, IL-23, and IL-17 secreted by the intervertebral disc cells. These cytokines promote extracellular matrix degradation, chemokine production, and changes in the intervertebral disc. The resulting imbalance in catabolic and anabolic responses leads to the degeneration of the intervertebral disc, as well as disc herniation and radicular pain. The release of chemokines from the degenerating disc promotes the infiltration and activation of immune cells, further amplifying the inflammatory cascade. Leukocyte migration into the intervertebral disc is accompanied by the appearance of microvascular tissue and nerve fibers. Annulus cells exposed to inflammatory cytokines and chemokines respond to shear with a dramatic and sustained increase in the cytoplasmic free calcium concentrations 6 to 10 times over the base levels, leading to the formation of osteophytes. Cytokines appear to sensitize the annulus cells to mechanical load. This increased responsiveness to mechanical load in the face of inflammatory cytokines implies that the sensitivity of the annulus cells to shear increases during inflammation and initiates progression of discdegeneration. Repetitive biomechanical stress and the immune response to bacterial end products leads to the inflammatory changes in the annulus fibers of the intervertebral disc. Thank you for watching Module 1 of Mastering the Gut program. You may now take the quiz prior to moving on to Module 2.